Hello, everyone. In today's episode, we are discussing schizophrenia and other psychotic disorders. What is schizophrenia? Schizophrenia is a serious mental disorder in which people interpret reality abnormally. Schizophrenia may result in some combination of hallucinations, delusions, and extremely disordered thinking, and behavior that impairs daily functioning and can be disabling. People with schizophrenia require lifelong treatment. Early treatment may help get symptoms under control before serious complications develop and may help improve the long-term outlook. Etiology. The exact causes of schizophrenia are unknown. Research suggests a combination of physical, genetic, psychological, and environmental factors can make a person more likely to develop the condition. Some people may be prone to schizophrenia, and a stressful or emotional life event might trigger a psychotic episode. However, it's not known why some people develop symptoms while others do not. Here are some risk factors of schizophrenia. First is genetics. It's more likely that different combinations of genes make people more vulnerable to the condition. However, having these genes does not necessarily mean you'll develop schizophrenia. Second is pregnancy and birth complications. Research has shown people who develop schizophrenia are more likely to have experienced complications before and during their birth, such as a low birth weight, premature labor, and a lack of oxygen during birth. Third is brain development. Studies of people with schizophrenia have shown there are differences in the structure of their brains. These changes are not seen in everyone with schizophrenia and can occur in people who do not have mental illness, but they suggest schizophrenia may partly be a disorder of the brain. Fourth is neurotransmitters. Research suggests schizophrenia may be caused by a change in the level of two neurotransmitters. These are dopamine and serotonin. Another risk factors includes triggers. Triggers are things that can cause schizophrenia to develop in people who are at risk. These include stress. The main psychological triggers of schizophrenia are stressful life events such as bereavement, losing your job or home, divorce, the end of a relationship, physical, sexual, or mental abuse. Another risk factors is drug abuse. Drugs do not directly cause schizophrenia, but studies have shown drug misuse increases the risk of developing schizophrenia or a similar illness. Certain drugs, particularly cannabis, cocaine, LSD, or amphetamines, may trigger symptoms of schizophrenia in people who are susceptible. Phases of schizophrenia. First is prodromal phase. Occurs before hospitalization or within the year, characterized by clear decline from his previous level of functioning, may withdraw from friends, families, and hobbies. Second phase is active phase. Commonly triggered by a stressful event, characterized by presence of acute psychotic symptoms, example, hallucinations, delusions, incoherence, and catatonic behaviors. Prognosis worsens with each acute episode. And the last phase of schizophrenia is residual phase. This is at this point in which illness pattern is established, disability level may be stabilized, and late improvements may occur. Types of schizophrenia. First is paranoid, characterized by persecutory delusional thought content and delusional jealousy. Stress may worsen patient symptoms, experience frequent auditory hallucinations but lack symptoms of other subtypes like incoherence, loose associations, and affect problems. Tend to be less severely disabled than other schizophrenics and are more responsive to treatments. Second is disorganized, marked by incoherent disorganized speech and behaviors and blunted or inappropriate affect. Usually includes extreme social impairment and starts early and insidiously with no significant remissions. The third one is catatonic, a rare disease form characterized by fixed positions for long periods and periodically yielding to brief spurts of extreme excitement, increased potential for destructive and violent behaviors when agitated. They remain mute and have refusal to move about or tend to personal needs. The fourth one is undifferentiated. Presence of schizophrenic symptoms such as delusions and hallucinations in patients who does not fall to the category of other subtypes. And the last one is residual, muted form of the disease that stops short of recovery, no prominent psychotic symptoms, and has history of acute schizophrenic episodes and persistence of negative symptoms. Signs and symptoms of schizophrenia. Signs and symptoms are divided into three clusters. This includes positive, negative, and cognitive symptoms. So first is positive symptoms. Deviant symptoms. These are symptoms that are present but should be absent. They indicate that patient has lost touch with reality. Primarily include delusions and hallucinations. Hallucinations are the most common feature of schizophrenia. These involve hearing, seeing, smelling, tasting, and feeling touched by things in the absence of stimuli. An example is hearing voices that command the patient to do certain things, usually abusive and destructive. Delusions are fixed, false beliefs. They cannot be changed by logic or persuasion. Several categories of delusions include persecutory delusions. Patient thinks he is being tormented, followed, tricked, or spied on. Reference delusions. Patient thinks that passages in books, music, TV shows, and other sources are directed at him. And lastly, delusions of thought withdrawal or thought insertion. Patient believes others can read his mind, his thoughts are being transmitted to others, or outside forces are imposing their thoughts or impulses on him. Next is negative symptoms. This includes deficit symptoms. These symptoms reflect the absence of normal characteristics. Apathy, lack of interest in people, things, and activities. Poverty of speech, a speech that is brief and lacks content. Blunted affect, characterized by patient's face appearing immobile and inexpressive. This is the flattening of emotions and becomes more pronounced as the disease progresses. Then lastly is cognitive symptoms. This includes reflect the patient's abnormal thinking, poor decision-making skills, poor problem-solving skills, and ability to communicate, and his strange behavior. Thought disorder is characterized by confused thinking and speech, for example, incoherent rumblings, loose association, word salad, and wandering. Then, bizarre behavior include childlike silliness, laughing or giggling, agitation, inappropriate appearance, hygiene, and conduct. Defense mechanisms. First is projection. This occurs when a person's own unacceptable and threatening feelings are repressed and attributed to someone else. For example, a schizophrenic on a psychiatric ward may accuse another patient of wanting to harm him because he himself feels aggressive toward that individual. Second is regression. This occurs when a person reverts to a previous phase of psychological development. For example, when an adult schizophrenic sleeps with a teddy bear. Third is denial. Denial can amount to an individual seeing the world from an artificially optimistic viewpoint, and even though they do not recognize their own artifice, they engage in denial of the reality of their mental health disorder. Fourth is reaction formation. This occurs when a feeling that produces unconscious anxiety is transformed to its opposite in consciousness. This may occur, for example, when a schizophrenic processes to enjoy group therapy even though it actually makes him very nervous to speak with others in a group setting. Therapy. Types of psychotherapy. First is individual psychotherapy. During sessions, a therapist or psychiatrist can teach the person how to deal with their thoughts and behaviors. Second is cognitive behavior therapy. This can help the person change their thinking and behavior. A therapist will show them ways to deal with voices and hallucinations. The third one is cognitive enhancement therapy. This type of therapy is also called cognitive remediation. It teaches people how to better recognize social cues or triggers and improve their attention, memory, and ability to organize their thoughts. Another therapy is called psychosocial therapy. This includes social skills training. This type of instruction focuses on improving communication and social interactions. Rehabilitation. Schizophrenia usually develops during the years we are building our careers, so rehabilitation may include job counseling, problem-solving support, and education in money management. Family education. Your knowledge of psychosis and schizophrenia can help a friend or family member who has it. Research shows that people with schizophrenia who have a strong support system do better than those without the encouragement of friends and family. Coordinated specialty care. This is for people experiencing an episode of psychosis for the first time. It's a team approach that combines medication and psychological therapies. It includes social and employment services and tries to include the family whenever possible. The aim is to change the direction and prognosis for the disease by catching it in its earliest stages. Assertive community treatment. This offers highly personalized services to help people with schizophrenia meet life's daily challenges, like taking medications. ACT professionals also help them handle problems proactively and work to prevent crises. And lastly, social recovery therapy. This treatment puts the focus on helping the person set and achieve goals and building a sense of optimism and positive beliefs about themselves and others. Medical treatment. Medications are the cornerstone of schizophrenia treatment, and antipsychotic medications are the most commonly prescribed drugs. They're thought to control symptoms by affecting the brain neurotransmitter such as dopamine. First is second-generation antipsychotics. These newer second-generation medications are generally preferred because they pose a lower risk of serious side effects than first-generation antipsychotics. First-generation antipsychotics. These first-generation antipsychotics have frequent and potentially significant neurological side effects, including the possibility of developing a movement disorder that may or may not be reversible. And lastly, long-acting injectable antipsychotics. Some antipsychotics may be given as an intramuscular or subcutaneous injection. They are usually given every 2 to 4 weeks, depending on the medication. This may be an option if someone has preference for fewer pills and may help with adherence. Another therapy is electroconvulsive therapy. Rarely used, but it is for patients with acute schizophrenia and those who cannot tolerate or don't respond to medication. It is effective in reducing depressive and catatonic symptoms of schizophrenia. Nursing management. Here are some nursing management for schizophrenia. Recognize schizophrenia. Note characteristic signs and symptoms of schizophrenia. For example, speech abnormalities, thought distortions, and poor social interactions. Establish trust and rapport. Don't tease or joke with patients. Expect that patient is going to put you through rigorous testing periods. Introduce yourself and explain your purpose. Maximize level of functioning. Assess patient's ability to carry out activities of daily living. Assess positive symptoms. Assess for command, hallucinations. Explore answers. Assess if the client has fragmented, poorly organized, well organized, systematized, or extensive system of beliefs that are not supported by reality. Assess negative symptoms. Assess for the negative symptoms of schizophrenia. Assess medical history. Assess if the client is on medications and what are these and the adherence to therapy. Assess support system. Determine whether the family is well informed about the disease. Ethical legal considerations. Telling half-truths to patients with schizophrenia who are paranoid. The conflict between truth-telling and doing good may be faced by any psychiatrist who considers withholding information from a patient regarding his or her likely psychodynamics or at most underlying emotional needs. Psychiatrists routinely choose to initially withhold certain types of knowledge because if they disclose everything right away, they run the risk of patients never returning and therefore not receiving adequate care. Ethically, the degree to which a psychiatrist withholds information may disrespect a patient's autonomy and may even be regarded as lying by omission. However, this ethical price may be warranted due to other competing and mutually exclusive values that may benefit the patient in other ways. Other psychotic disorders. First is Schizophreniform Disorder. Second, Schizoaffective Disorder. Third, Delusional Disorder. Fourth, Brief Psychotic Disorder. And lastly is Shared Psychotic Disorder. So what is Schizophreniform Disorder? It is a type of psychotic illness with symptoms similar to those of schizophrenia, but lasting for less than 6 months. Like schizophrenia, schizophreniform disorder is a type of psychosis in which a person cannot tell what is real from what is imagined. It is also affects how people think, act, express emotions, and relate to others. If symptoms last longer than 6 months, doctors consider the person to have schizophrenia rather than schizophreniform disorder. Etiology. Doctors don't know what causes schizophreniform disorder. A mix of factors may be involved, including genetics. A tendency to develop schizophrenia and schizophreniform disorder may pass from parents to their children. Next is brain structure and function. People with schizophrenia and schizophreniform disorder may have a disturbance in brain circuits that manage thinking and perception. If you have schizophrenia or schizophreniform disorder, you might have an imbalance of certain chemicals in the brain. These chemicals, called neurotransmitters, are substances that help nerve cells in the brain send messages to each other. An imbalance in these chemicals can interfere with the transmission of messages, leading to symptoms. Next is environment. Poor relationships or very stressful events may trigger schizophreniform in people who have inherited a tendency to develop the illness. Pathophysiology. Anatomic, neurotransmitter, and immune system abnormalities have been implicated in the pathophysiology of this disorder. Patients with schizophreniform disorder and patients with schizophrenia share many anatomic and functional cortical deficits on neuropsychological studies, magnetic resonance imaging, and single photon emission computed tomography, and positron emission tomography. Patients with schizophreniform disorder and schizophrenia were less able to form an internal representation of complex objects. Such neuropsychological tests help clinicians further understand the psychology of the disorder. Signs and symptoms. Schizophreniform disorder is distinguished by its duration. An episode of the disorder lasts at least 1 month but less than 6 months. This includes delusions, hallucinations, disorganized speech such as not making sense, using nonsense words, and skipping from one topic to another. Lack of energy, poor hygiene and grooming habits, loss of interest or pleasure in life, odd or strange behavior such as pacing, walking in circles, or writing constantly, and lastly, withdrawal from family, friends, and social activities. Defense mechanism. For some people, paranoid schizophreniform may be episodic, in that episodes of acute psychosis and even prolonged episodes of psychosis may abate as a result of the predominantly unconscious application of defense mechanisms to the painful realities of psychosis, from which the schizophrenic individual seeks relief. The use of repression and denial to combat psychic pain constitutes an explanation why some schizophrenics go into remission periodically. The fact of the use of denial and repression as a means of combating psychic pain in schizophreniform may be counterintuitive as an explanation why some schizophrenics may go into remission regarding their illness. Medical management. First is medication. The primary medications used to treat the psychotic symptoms of schizophreniform, such as delusions, hallucinations, and disordered thinking, are called antipsychotics. A group of newer medicines called atypical antipsychotics are most commonly used. This includes risperidone, clozapine, quetiapine, ziprasidone, olanzapine, aloperidone, paliperidone, asinapine, and lorazepam. Psychotherapy. The goal of therapy is to help you learn about the illness, establish goals, and manage everyday problems related to the disorder. Family therapy can help families deal more effectively with a loved one who has schizophreniform disorder, enabling them to contribute to a better outcome. Nursing management. Initially, a mental examination should be performed identifying the present symptomatology such as delusions, hallucinations, disorganization, and negative symptomatology. It is important not to discuss or deny belief so as not to risk compromising trust. One should also reinforce reality and talk about things and people that are real, avoiding ruminant thinking in false beliefs. The nurse should also be attentive during feeding and taking medication, since the delirium of poisoning may be present and the patient may believe that the food or medication is to poison him. The nurse must observe certain signs. In the presence of these signs, the nurse should avoid touching the patient without warning, as the touch may be understood as a threat. Nurses must display an attitude of acceptance to help the patient share the content of the hallucination. Ethical legal considerations. Ethical concerns about schizophrenia have been raised, for the most part, because of concerns about the decision-making capacity of the patient. Schizophreniform is a disorder of disturbed thinking, and so it was reasoned that if thinking is disturbed, then the capacity to consent is likely to be compromised. As a result, individuals with schizophreniform disorder have long been considered a vulnerable population in the research setting. There are 5 main areas where ethical issues have been and continue to be particularly prominent in schizophrenia research. First, competency of participants and informed consent. Second, exclusion of suicidal patients from research on schizophrenia. Third, early intervention with prodromal patients. Fourth, medication withdrawal and medication-free protocols. And lastly, genetic research on schizophrenia. Schizoaffective Disorder. This disorder is a mental illness that can affect your thoughts, mood, and behavior. You may have symptoms of bipolar disorder and schizophrenia. These symptoms may be mania, depression, and psychosis. About 1 in 200 people develop schizoaffective disorder at some time during their life. The two types of schizoaffective disorder, which include some symptoms of schizophrenia, are bipolar type, which includes episodes of mania and sometimes major depression, and the second one is depressive type, which includes only major depressive episodes. Etiology. The term schizoaffective disorder first appeared as a subtype of schizophrenia in the first edition of the DSM. It eventually became its own diagnosis despite lack of evidence for unique differences in etiology or pathophysiology. Therefore, there have been no conclusive studies on the etiology of the disorder. However, investigating the potential causes of mood disorders and schizophrenia as individual disorders allows for further discussion. Some studies show that as high as 50% of people with schizophrenia also have comorbid depression. The pathogenesis of both mood disorders and schizophrenia is multifactorial and covers a range of risk factors including genetics, social factors, trauma, and stress. Among people with schizophrenia, there is a possible increased risk for first-degree relatives for schizoaffective disorder and vice versa. There may be increased risk among individuals for schizoaffective disorder who have a first-degree relative with bipolar disorder, schizophrenia, or schizoaffective disorder. Pathophysiology. The exact pathophysiology of schizoaffective disorder is currently unknown. Some studies have shown that abnormalities in dopamine, norepinephrine, and serotonin may play a role. Also, white matter abnormalities in multiple areas of the brain, particularly the right lentiform nucleus, left temporal gyrus, and right precuneus, are associated with schizophrenia and schizoaffective disorder. Researchers have also found reduced hippocampal volumes and distinct deformations in the medial and lateral thalamic regions in those with schizoaffective disorder in comparison to controls. Signs and symptoms. First is delusions, having false, fixed beliefs despite evidence to the contrary. Hallucinations, such as hearing voices or seeing things that aren't there. Impaired communication and speech, such as being incoherent. Bizarre or unusual behavior, symptoms of depression, such as feeling empty, sad, or worthless. Periods of manic mood with an increase in energy and a decreased need for sleep over several days, and behaviors that are out of character. Impaired occupational, academic, and social functioning. Problems with managing personal care, including cleanliness and physical appearance. Manic behavior. If a person has been diagnosed with schizoaffective disorder, bipolar type, they will experience feelings of euphoria, racing thoughts, increased risky behavior, and other symptoms of mania. Defense mechanisms. Repression. This occurs when a threatening idea, thought, or emotion enters consciousness. This defense mechanism causes repression of threatening material or intrusive thoughts. Using this defense mechanism, one may engage in any of the other defense mechanisms. Projection. This occurs when a person's own unacceptable and threatening feelings are repressed and attributed to someone else. For example, a schizophrenic on a psychiatric ward may accuse another patient of wanting to harm him because he himself feels aggressive toward that individual. Displacement. This occurs when people direct their emotions to things or animals and other people that are not the real object of their feelings. For example, a psychotic individual may try to punch a smaller person rather than the individual whom he is actually angry at because he fears the other larger person. And lastly, reaction formation. This occurs when a feeling that produces unconscious anxiety is transformed to its opposite in consciousness. This may occur, for example, when a schizophrenic professes to enjoy group therapy even though it actually makes him very nervous to speak with others in a group setting. Therapy. Schizoaffective disorder is treated and managed in several ways. First is psychotherapy. Patients who have schizoaffective disorder can benefit from psychotherapy. As is the case with most mental disorders, treatment plans should incorporate individual therapy, family therapy, and psychoeducational programs. The aim is to develop their social skills and improve cognitive functioning to prevent relapse and possible rehospitalization. This treatment plan includes education about the disorder, etiology, and treatment. Next is individual therapy. This type of treatment aims to normalize thought processes and better help the patient understand the disorder. To reduce the burden of symptoms, sessions focus on everyday goals, social interactions, and conflict. This includes social skills training and vocational training. Next is family or group therapy. Family involvement is a crucial in the treatment of this schizoaffective disorder. Family education aids in compliance with medications and appointments and helps provide structure throughout the patient's life given the dynamic nature of the schizoaffective disorder. Next is ECT or Electroconvulsive Therapy. ECT is usually a last resort treatment. However, not only has it been used in urgent cases and treatment resistance, but it should also merit consideration in augmentation of current pharmacotherapy. The most common indicated symptoms are catatonia and aggression. ECT is safe and effective for most chronically hospitalized patients. Medical management. In general, doctors prescribe medications for schizoaffective disorder to relieve psychotic symptoms, stabilize mood, and treat depression. These medications may include: first is antipsychotics. The only medication approved by the Food and Drug Administration specifically for the treatment of schizoaffective disorder is the antipsychotic drug paliperidone. However, doctors may prescribe other antipsychotic drugs to help manage psychotic symptoms such as delusions and hallucinations. Next is mood stabilizing medications. When the schizoaffective disorder is bipolar type, mood stabilizers can help level out the mania highs and depression lows. Antidepressants. When depression is the underlying mood disorder, antidepressants can help manage feelings of sadness, hopelessness, or difficulty with sleep and concentration. Nursing management. Advise patient to change lifestyle. Lifestyle changes can help cope with the challenges of a mental condition and decrease worsening of symptoms. Lifestyle lifestyle changes may include striving for a regular daily routine, aiming for a healthy diet and regular physical activity, identifying stressors and trying to avoid them, keeping your home environment calm and relaxed, avoiding alcohol and illegal drug use. Talk to your doctor if you are currently using drugs or drinking alcohol regularly and have trouble controlling your habits. Ethical legal considerations. Asking a patient with schizoaffective whether he or she wants to write psychiatric advance directives. Analogously, a psychiatrist can ask a patient with schizophrenia who still has decisional capacity what his or her wishes are regarding his or her care should he or she lose decisional capabilities at a later time. These psychiatric advance directives enable the psychiatrist to predetermine several future outcomes, including where the patient will be hospitalized, which psychiatrist will treat the patient, and what medications will be given to the patient. By allowing the patient to participate in these decisions, the psychiatrist is respectful to the patient's autonomy and also able to provide optimal medical care. Some patients may not want to pursue this option. Something to further consider is that a psychiatrist who presents this option to a patient may cause the patient exceptional fear, which could make the patient's schizophrenic illness worse. Delusional disorder. So, what is delusional disorder? A type of extreme psychiatric disease called a psychotic condition is delusional disorder, formerly called paranoid disorder. People who have it cannot tell from what is imagined from what is real. Delusions are the main symptom of delusional disorder. They're unshakable beliefs in something that isn't true or based on reality. But that doesn't mean they're completely unrealistic. Although might be a symptom of more common disorders, such as schizophrenia, delusional disorder itself is rather rare. Delusional disorder most often happens in middle to late life and is slightly more common in women than in men. Etiology. The exact cause of delusional illness is not known yet, as in many other psychotic illnesses. However, researchers are looking at the function of different genetic, biochemical, and environmental or psychological variables. First is genetic. Among those who have family members with delusional illness or schizophrenia, the fact that delusional disorder is more widespread indicates that there may be a genetic component involved. It is suspected that the potential to develop psychotic illness could be passed on from parents to their offspring, as with other mental disorders. Next is biological. Researchers are researching how abnormalities may be implicated in the development of delusional conditions in some regions of the brain. And deficiency of some brain, called neurotransmitters, has also been correlated with the production of psychotic symptoms. Neurotransmitters are chemicals that help convey signals to each other from nerve cells in the brain. The delivery of signals can interfere with an imbalance in these chemicals, contributing to symptoms. Lastly, we have environmental or psychological. Evidence suggests that stress can be caused by delusional disorder. Alcohol and substance misuse may also lead to the disease. People who tend to be isolated appear to be more vulnerable to the development of delusional disorder, such as immigrants or those with poor sight and hearing. Pathophysiology. Most strongly linked to the pathophysiology of psychotic disorders is the neurotransmitter dopamine. The positive symptoms of psychotic disorders are believed to be caused by excess dopamine in the mesolimbic tract. Glutamate, an excitatory neurotransmitter, is also implicated. Evidence suggests that delusional disorder can be triggered by stress. Alcohol and abuse also might contribute to the condition. People who tend to be isolated, such as immigrants or those with poor sight and hearing, appear to be more vulnerable to developing delusional disorder. Signs and symptoms. The most obvious symptom of this disorder is the presence of non-bizarre delusions. Additional symptoms that may appear include irritable, furious, or low mood. Hallucinations that are associated with delusion, such as seeing, hearing, or feeling things that are not really there. A persistent delusion or delusions, for example, about a situation, condition, or action that is not happening but may be plausible in real life. These include erotomanic, delusion of a special loving relationship with another person, usually someone famous or of higher standing. This kind of delusion is sometimes at the root of stalking behavior. Grandiose, delusion that the person has a special power or ability or a special relationship with a powerful person or figure, such as the president, a celebrity, or the pope. Jealous, delusion that a sexual partner is being unfaithful. Persecutory. Delusion that the person is being threatened or maltreated. Somatic. Delusion of having a physical illness or defect. Defense mechanism. Defense mechanism used is denial. This occurs when people refuse to admit that something unpleasant is happening to them. This can result in a person saying that their medication is working even though this is not true. Denial can amount to an individual seeing the world from an artificially optimistic viewpoint, and even though they do not recognize their own artifice, they engage in denial of the reality of their mental health disorder. Therapy. We have psychosocial therapy. Individual psychotherapy can help the person recognize and correct the underlying thinking that has become distorted. Cognitive behavioral therapy helps the person learn to recognize and change thought, patterns, and behaviors that lead to troublesome feelings. Family therapy can help families deal more effectively with a loved one who has delusional disorder, enabling them to contribute to a better outcome for the person. Medical management. Medications. The primary medications used to attempt to treat delusional disorder are called antipsychotics. Medications include the following. First, we have conventional antipsychotics, also called neuroleptics, have been used to treat mental disorders since the mid 1950s. These medicines work by blocking dopamine receptors in the brain. Dopamine is a neurotransmitter believed to be involved in the development of delusions. Next is newer medications. This is also called atypical antipsychotic drugs, appear to be more effective in treating the symptoms of delusional disorder. These medications work by blocking dopamine and serotonin receptors in the brain. Serotonin is another neurotransmitter believed to be involved in delusional disorder. Then we have other medications that might be used to treat delusional disorder include tranquilizers and antidepressants. Tranquilizers might be used if the person has a high level of anxiety or problem sleeping, while antidepressants might be used to treat depression, which often occurs in people with delusional disorder. Nursing management. Provide patient with honest and consistent feedback in non-threatening manner. Avoid challenging the content of patients' behaviors. Focus interactions on patients' behaviors. Administer drugs as prescribed while monitoring and documenting patients' response to the drug regimen. Use simple and clear language when speaking with patient. Encourage patient to talk about feelings in the context of a trusting, supportive relationship. Allow patient time to reveal delusions to you without engaging in a power struggle over the content or the reality of the delusions. Use a supportive, empathic approach to focus on patients' feelings about troubling events or conflicts. Ethical legal considerations. Clinicians who treat patients with psychotic disorders may encounter a variety of ethical issues related to both psychiatric and medical treatment of patients. While informed consent is a crucial aspect of the care of all patients, it may present special challenges for patients with psychotic disorders. It is a severe mental illness that is frequently accompanied by neuropsychological deficits. These impairments, as well as psychotic symptoms and lack of insight, can affect patients' abilities to make fully informed decisions about their own care. Ensuring that consent for treatment is informed, voluntary, and competent can thus become a more difficult endeavor. Next is we have brief psychotic disorder. Brief psychotic disorder is a sudden, short-term display of psychotic behavior such as hallucinations or delusions, which occurs with a stressful event. Etiology and pathophysiology. Brief psychotic disorder is triggered by extreme stress, such as a traumatic accident or loss of a loved one. It is followed by a return to the previous level of function. The person may or may not be aware of the strange behavior. This condition most often affects people in their 20s, 30s, and 40s. Those who have personality disorders are at high risk of having a brief reactive psychosis. The pathophysiology of brief psychotic disorder is not known, especially given the extremely low incidence of the disorder. Its higher prevalence among patients with personality or mood disorders may suggest underlying biological or psychological susceptibility, which may some genetic influence. Signs and symptoms. First is delusions, beliefs that have no basis in reality. Next is hallucinations. For example, hearing voices or other noises that not based in reality, seeing or otherwise perceiving things not actually present in any way. Next is disorganized speech, frequently off topic or nonsensical. And lastly, we have severely disorganized or catatonic behavior. Defense mechanisms. The psychotic DMRS has been developed to include 6 psychotic defense mechanisms. First, we have psychotic denial. This is a form of denial that is so extreme as to fall under the category of delusion. Then, distortion involves a person believing something to be true when it is not. In some cases, distortion can protect a person from the uncomfortable reality of a situation. Then, delusional projection refers to a defense mechanism that involves attributing unacceptable thoughts, emotions, and impulses to another source that is not based in reality. And lastly, we have concretization. In concretization, the subject deals with internal or external stressors by transforming a mental representation into a concrete object, situation, or action. Therapy and medical management. Therapy, psychotherapy is a type of counseling or talk therapy. The goal is to help the person identify and handle the situation or event that triggered the disorder. Drug therapy. The doctor might prescribe antipsychotic drugs to ease or eliminate the symptoms and the brief psychotic disorder. The FDA hasn't approved any medicines specifically to treat psychotic disorder. Doctors often prescribe antipsychotics that are used to treat schizophrenia. These include chlorpromazine, flufenazine, haloperidol, and loxapine. Newer medications, which doctors call atypical antipsychotic drugs, include aripiprazole, asenapine, brexpiprazole, and clozapine. If someone with this condition is very anxious or has problems with sleep, their doctor may prescribe tranquilizers such as diazepam and lorazepam. Nursing management. Assess patient's response to prescribed antipsychotic drug. Collaborate with patient and occupational and physical therapy specialists to assist patient's ability to perform activities of daily living. Collaborate with patient to establish a daily achievable routine within physical limitations. Teach strategies to manage adverse effects of antipsychotic drug that affect patient's functional status. Monitor patient for behaviors that indicate increased anxiety and agitation. Use simple and clear language when speaking with patient. Explain all procedures, tests, and activities to patient before starting them, and provide written or video material for learning purposes. Ethical legal considerations. The ethical principles underlying treatment of these patients, however, are the same as those guiding treatment of all patients. Informed consent as an embodiment of these ethical principles represents the expression of individual rights in both clinical and research contexts. Attention to the process of informed consent as an ongoing dialogue strengthens the clinician-patient relationship, improves adherence, and helps the patient clarify options, values, and preferences. And lastly, we have shared psychotic disorder. Shared psychotic disorder, or folie à deux, is an uncommon mental disorder characterized by sharing a specific delusion among two or more people who are in a close relationship. The primary who has a psychotic disorder with delusions influences another individual or more secondary with a specific belief. It commonly presents among two individuals, but in rare cases can include larger groups, family, and called fully a family. Etiology. The exact cause of shared psychotic disorder is still unknown. However, certain risk factors associated with it includes length of a relationship. Numerous studies highlight the role of the long relationship duration as an essential factor for developing this condition. Nature of the relationship. The majority of cases reported were among family members. Social isolation. Most cases reported poor interaction with society. An individual who is confused and perplexed can undergo influence under frightening conditions in the absence of social comparison. Personality disorder. Individuals usually show features of a personality defect. The usual description for them is a neurotic, introvert, and emotionally immature. Untreated mental disorder in the primary. An untreated individual with chronic mental conditions could be a social risk factor of influence to the other member of the family. Cognitive impairment. It has been noted that the secondaries lacks good judgment and intelligence. Comorbidity of the secondary. An individual diagnosed with a mental disorder, especially schizophrenia, bipolar affective disorder, depression, dementia, or mental retardation, carries a risk to be influenced by another mentally ill person. Life events. Stressful life events that affect the relationship could influence behavior in the individual to accept certain delusions or lessening the ability to resisting the feelings or emotions. Communication difficulties. Having difficulties in sharing ideas could be a reason for preferring isolation. Age. Previous studies reported age differences, the elderly being a dominant while the young being submissive, but recent studies does not support these findings. And lastly, we have gender. It is more common among females to be part of this disorder, both as a primary or secondary. Pathophysiology. The condition is usually chronic and both the dominant and submissive individual share the original delusions. The sharing of delusions occurs under unique circumstances. The shared delusions could be of any type. There are racial variations. The common types of delusions are persecutory, followed by grandeur. In Japanese communities, persecutory delusions were the common, followed by religious delusions. There could be other psychiatric features such as social withdrawal, hallucinations, or suicidal thoughts. The functionality is generally preserved compared with other disorders. There may be significant impairment in a particular aspect of life. When the delusions are not confronted, the person cannot maintain a normal lifestyle. The concept of the dominant submissive relationship derived from the psychodynamic theory. The role of the primary is rigid and possessing a dominant role in the relationship, while the submissive being less intelligent, passive, less resilient to suggestions, isolated, and physically handicapped. Some authors even emphasize the existence of a reversal role between partners due to the complexity of the disorder. The signs and symptoms of shared psychotic disorders are presence of dominant person with psychotic disorder, bizarre delusion that seem believable, firm and unshakable belief in dominant person's delusion. Defense mechanism. When psychotic symptoms are explained as a natural defense mechanism that is out of control, treatment can focus on the strengthening of the underlying vulnerability and regaining cognitive control instead of curing the psychotic symptoms. Interventions that can train higher cognitive functioning, reduce stress, or increase self consciousness could help people with psychosis to regain control from the inside. Therapy and medical management. Therapy. Psychotherapy can help the person with shared psychotic disorder recognize the delusion and correct the underlying thinking that has become distorted. It also can address a relationship issues and any emotional effects of a short term separation from the person with a psychotic disorder. Family therapy might focus on increasing exposure to outside activities and interests, as well as the development of social supports to decrease isolation and help prevent relapse. Family therapy also might help to improve communication and family dynamics. Medical management. If the symptoms continue even after separating from the person from their contact who has a psychotic disorder, they may need to take antipsychotic medicines for a short period of time. Sometimes, doctors also prescribe tranquilizers or sedatives to ease intense symptoms such as anxiety, extreme restlessness, or insomnia. Nursing management. Patients with shared psychotic disorder could be because only the primary partner gets registered for treatment in a classical presentation. The level of tolerance and harmony among the two patients both could add a significant challenge to the clinician to identify every partner's role. Awareness is necessary regarding the nature of the dyad relationship dynamics and to manage it extensively. Most patients lack insight, which causes a substantial barrier to early discovery and management. The failure to adhere to treatment is an additional challenge to the clinician. A key aspect to the understanding the impact of the delusions on both partners' life. A board certified psychiatric pharmacist should work with the team to select the best agents for optimal therapeutic results with minimal adverse effects. And lastly, a holistic approach that assesses and manages the biopsychosocial factors should help for a better outcome. The psychotherapist, mental health nurse, and psychiatrist should continue to follow these patients as relapse is common due to non-compliance with treatment. Ethical legal considerations. Psychiatrists who care for people with psychotic disorders face specific ethical challenges in their daily work. Treating people with disorder that can affect perception, interpretation, and making of meaning is inherently fertile ground for ethical dilemmas. The history of prolonged, often involuntary, treatment of people with psychotic disorders has influenced generations of providers toward paternalistic approaches to care. Psychiatric research has several important ethical issues which are different from other medical disciplines. These issues are related to informed consent, confidentiality, conflict of interest, therapeutic misconception, placebo related, vulnerability, exploitation, operational challenges, among others. So that is the end of our discussion in today's episode. Thank you for watching.